All right, good morning, folks, and welcome to Friday Chalk Talk. My name is Martin, and I will be your host and moderator today. This morning, we have a discussion on methadone conversions. And if you haven't already, we really recommend that you utilize McPherson's demystifying opiate conversion calculations. It's a wonderful source of material for this topic. Today, I have the pleasure of introducing our guest, Peter Stussy. This is his third time back on the show with us. Peter is our superhero clinical pharmacy specialist in oncology who partners with our palliative medicine team here in Milwaukee. And honestly, there's no one else that I would trust more to talk with us about this subject today. So, Peter, I will hand the mic over to you, sir.
Thanks, Marty. Can you hear me okay? All good? All right, excellent. So as he's so wonderfully introduced, we're going to be talking about methadone conversions today, and definitely going to state that I have nothing financially or business-wise towards this, but there's definitely bias in how these are done by the person. There are various different methods, various ways to go about this. So I will state that I will be bringing up my own opinions based off of my experience and interpretation of the literature today, for sure. So we're going to, there's a lot of literature out there. So I wanted to scope this particular discussion today so people knew what we were going to be really covering. I don't cover all the literature that's out there, but I do, as Martin said, I'll focus on McPherson's book primarily today, since she has summarized so wonderfully so much of the literature that is out there right now and summarized it. But I will throw in some primary sites as well. The focus here is going to be on conversions from patients who are currently on opiate treatment. We're not going to talk about naive patients starting methadone. Going to briefly mention all the wonderful stuff that's out there on drug interactions, QT prolonging, unique pharmacokinetics, exactly in the context of conversions, but we're not going to spend a ton of time on the details. We're going to stick with oral methadone today, so I won't be talking about parenteral PCAs or converting to parenteral doses, but please know that's definitely out there. And then we're going to be going from an opiate to methadone. We're not going to be going from methadone to other opiates today as well. We're going to just focus on the conversion to methadone. All right. So a couple of quick objectives, considerations about changing patients to methadone from other opiates, and then we'll work through some cases so we can demonstrate. So why would we want to convert? What are some possible candidates for methadone conversion? One of the aspects of methadone is that it's primarily hepatically metabolized, very, very, very insignificantly renally. So patients with renal dysfunction and things might be good candidates. Because of its unique pharmacodynamics at various receptors, neuropathic pain is also treated by methadone. So that may be a consideration in patients with mixed pain disorders. Refractory to other opiates or having uncontrolled pain or hyperalgesia, methadone's been shown to assist in those cases as well. It's cheap and it is available IV, oral solution. There are various ways we can administer methadone. So it's also very useful in patients who might not necessarily just have an oral tablet as their only option. And then it could be used in anybody needing opiate pain relief. I mean, it is a very good pain drug, plain and simple. So some patients where you might not want to is if you do recognize a lot of drug interactions. It does have some important ones that need to be addressed. If patients have that cardiac history, QT prolongation, it is dose-dependent QT prolongation with methadone. So the higher dose you get, the more QT prolongation you get. So lower doses generally do not impact too much, but if you have a patient on meds or a patient with long QT syndrome, probably not the best option. If they don't have a good support system or their cognitive functioning isn't at the point where they can really monitor their medications well. This is a medication that needs close monitoring and a patient or a support system that can help make sure they're taking things appropriately in order to limit the risk of adverse effects. If you don't have a practitioner who is good with methadone or familiar with methadone and uses it in the outpatient setting, you really shouldn't start somebody inpatient if they can't be followed, again, closely outpatient. It'll be a theme I'll bring up often through this is close monitoring. And then if they are going to be undergoing a definitive pain relief procedure soon, that is also another reason why you may not want to convert. All right, some of those factors that we wanted to, that I said we brought up, variable bioavailability makes it a very interesting drug. But what they have found in the literature is that most patients are around 80%. So the bulk of patients around 80%, but then you have those outliers where some are a little higher, some are a little lower. And traditionally, we've used an IV to PO ratio of 1 to 2. However, there is more recent literature saying that, with most patients having a higher bioavailability, maybe we should be using 1 to 1.3 or so, perhaps. So I did link that resource at the end on my references if you wanted to take a look at that. It distributes widely and quickly everywhere. It's highly lipophilic, so it has a pretty quick onset. But then because it distributes everywhere and then slowly redistributes back into the blood, it has a very long elimination half-life. As you can see, it can be from anywhere from 5 to 130 hours, depending on various things. It also induces its own metabolism. So as you continually dose it, the half-life actually gets a little shorter as you're moving along. So you have to be very careful in how quickly you adjust doses with methadone, which anyone who's dosed methadone and looked into this is very familiar with. Also, I forgot to note, it is highly protein bound, primarily to alpha-1 acid glycoprotein. So that may play into it. The protein levels in these patients may play into how much is unbound and available for the patient. As mentioned previously, drug interactions, inhibitors and inducers, primarily of CYP3A4, are the ones that you're really watching out for. And then it has that non-linear conversion from other opiates. So that's what I'll jump into on some of that situation in just a moment. So going through conversions, steps in converting, I'm going to go through the McPherson method today from demystifying opioid conversion calculations. There's a whole chapter on methadone. It is wonderful reading. And if you want to use methadone in your patient population, I highly recommend reading that chapter. So her first step is to globally assess the patient. Is this a good candidate? Is this somebody who we wouldn't have any of those kind of contraindications we should be using it in? Step 2 is determine total daily dose of opiate. Today, in our case examples, I'll be using the McPherson table for this particular presentation. I am going to make an assumption of the audience that we're quite familiar with the general moving to oral morphine equivalents. Step 3, we're going to convert that daily orphan equivalent dose to methadone. So that's where we get into a lot of discussion on methods and other ways to do it. So at our Aurora, here at this organization, at our hospice, inpatient hospice facility, and with our hospice at home patients they follow, here's the conversion chart that they use at this time. It's been used across the US for many years. Its original reference that I have for it is from a cancer chemotherapy handbook from 2003. So this is not a new conversion chart by any means. But there are definitely other options as well. McPherson, her book, this is what she uses, her recommendations here are definitely a lot more condensed. And she's far more conservative in her conversions. Instead of lots of different levels, she just goes with 10 to 1 and 20 to 1, depending on if you're less than 200 or greater than 200. So much simpler, much more direct, and then leads to recommendation to really rely on those as needed breakthrough meds for the first couple of days to really tell how much methadone they really truly need. Also, please note that they recommend a 40 milligram max, no matter what their previous opiate conversion dose was. All right, then the FDA, in the FDA labeling for methadone, has their own as well. So I want to make sure you're aware of what the government has in their labeling in this time. And they go off of percentages, so they have a range in there. Also wanted to note on this one, we have an opiate job aid at my organization as well. Aurora Pharmacy has it. And they just have you do a 1-to-1 conversion and then decrease by 75 to 90%. That is all the recommendation they give the pharmacy staff in this particular job aid. To say that I have recommended changes to that job aid is being very calm. I have shouted and yelled quite a bit on that one. So lots of other conversion tables do exist as well, but they're all pretty similar to what I've shown you thus far. But these are the ones that we're just, during our cases, we'll go through different ones and see what the numbers pop out at. So there's lots of different steps and ways to do it as well. I'm not going to walk through every single one of these. I just wanted to tell you that there's lots of different steps in how to choose the dose and then going through the days of titrating up, titrating down, etc. But here are some of them that are brought up in McPherson. A new one that is not brought up in McPherson that I found quite intriguing is this BGR method. The thought here is that 15 milligrams would be your starting dose in an opiate naive patient. And then the curve for what it would look like as far as the conversion would be a parabola. So they came up with a formula to kind of mimic that. And they validated their formula by looking at patient cases and what dose they ended up getting good pain control on with methadone. And it seemed to match up pretty good. I, again, listed the reference at the end, but I'll just bring this one up. And I'm intrigued. I have not used this method myself, but I'm intrigued by it. All right, so then the last two doses after converting to methadone is to individualize it. Do we have an acute pain crisis? Are there drug interactions where we should be maybe being a little bit more aggressive or less aggressive, depending on if it's an inducer or inhibitor? Do we have other comorbidities, that cachexia? Are they protein, probably low protein levels, so more free drug? Are they on a really high morphine equivalent where McPherson recommends don't use any more than 40 of methadone to start? And then you have to choose a breakthrough medication. Some do use methadone as that breakthrough medication. They give it every certain number of hours. I personally have never done that because I'm too concerned about accumulation over time of too many as needed doses. But it is definitely a method that is used out there. General recommendation is the same as you would do for anything, about 10 to 15% the oral morphine equivalent as a breakthrough from the total daily dose that's out there. All right, and step 5, patient monitoring. And McPherson calls this the most crucial step, and I agree. You really have to monitor these patients regularly. If you're inpatient, obviously that's not as big of a concern, but if you're starting this in an outpatient setting, you need to make sure that you are contacting these patients regularly, or else they call and you feel comfortable with them calling with any issues. So that's why it's very important to have those support people to help watch for signs of excess adverse effects, such as that solemnness, confusion, breathing changes, snoring is one common one as well. So there are definitely other excess adverse effects out there as well, but those are the ones that I'm just highlighting today. And then if outpatient, daily check-ins are really recommended on these patients. Then titrating, how often do you titrate the dose based off of effect? Depending on the reference you look at, it might give you a different range of days. McPherson gives 4 to 10, but then you look at different references, they'll say 5 to 7, they'll say 4 to 7. They'll say 5 to 10, etc. I think this comes back to individualization. What is happening during that monitoring with that patient on how often you'll titrate. All right, so I want to jump right into the cases. I'm hoping I'm not going to go too long here, and these are definitely interactive. Type in questions or anything in the chat, or just unmute and talk over me here, because this is the interactive part where I want us to discuss some things. I took these cases from the literature and my own experience, so they are in some cases real life scenarios, or else scenarios that I caught from the literature that were cases. Definitely changed things so we wouldn't call out any specific patients. So we have a 68-year-old male, severe osteoarthritis, but they also have regular bouts of electric shooting pain down both legs. Outpatient palliative is consulted for pain control, so this is an outpatient. And the current regimen is 60 of morphine sulfate extended release twice a day, and then 15 every 2 hours, and he takes about 5 a day on average. So decision's been made to switch to oral methadone, but keep the morphine IR, as the patient says that he's getting a good response when he uses that. All right, so global assessment. We have a wife at home who's very involved, so good patient there. No interacting drugs, cardiac diagnoses, so a good patient to try this switch on. So total daily opioid dose. Once again, I'm using the conversion chart in McPherson's book. So 120 ER plus 75 immediate release. So we got 195 oral methadone daily. And then here's our different conversions. We have our Aurora conversion table, which is one of the most popular in the US, saying 24 milligrams. The FDA says anywhere from 20 to 40. McPherson would go with a 10 milligram daily dose. The job aid at Aurora, I used the 90% reduction, would say 20. And then this new BGR method would say 36 milligrams at this point. So then here, you individualize. We have a patient who has regular acute pain, shooting pain in this particular circumstance. We have a patient who we feel very comfortable monitoring. So, in this particular case, I'll go on the next slide of what was done. But definitely think at this point, what would you start in a patient like this at this point?
Hey, Peter, can I jump in and add something as another alternative? I haven't done this very often, but maybe another choice would be to add methadone as an adjunct and continue the same baseline long and short acting morphine, if that is working most of the time, to get some bonus neuropathic adjunctive properties from the methadone, like maybe adding to the existing 2 milligrams twice a day.
Absolutely. Completely agree. I will go through an adjunctive case in a second as well, but it's a very different adjunctive case, very different. But I completely agree. That is very valid. In that case, what I've seen in my practice and recommended is anywhere from a 2.5 to 5 milligram start. Just give them a little and see what happens. You can just start that on a daily basis. If you wanted to do the 5 milligram split twice a day, that's fine too. But completely agree there as well. All right, so we'll just jump ahead in the interest of time. I don't want to take up everybody's day here. So in this case, they started 10 milligrams twice a day. And then they upped the as needed because they thought that they felt they weren't getting good enough pain relief. So they went up to 20 every 2 hours. But on day 2, this patient calls in, reports great pain control and no PRNs needed at all. So that should be a sign to you that something's wrong with methadone, okay? We know over time it takes multiple days to get up to steady state. So if we're going to continue repeat dosing here, if they have great pain control already after just a day, then we're going to get higher levels over the next several days. So that's when you need to be concerned about issues. And that's exactly what happened to this particular patient. The next day, the patient wife called and they reported confusion and a lot of snoring the night before. What was done in this case is they held the doses on day 3, and on day 4, he seemed back to baseline, and they started 5 milligrams 3 times a day. At that point, they moved it down, and then from days 5 to 7, they only reported taking 2 breakthrough doses, seemed to not have as much of that shooting pain, so it seemed to work very well in this particular case. There are definitely more than, I wanted to give this as an example of when to be concerned about really great pain control early on, because it takes time for that methadone to come up. All right, next one is an adjunctive. So we have a 52-year-old female, locally metastasized pancreatic cancer, admitted for bowel perf. They titrated all the way up to hydromorphone at 9 milligrams an hour, plus a 2 milligram every 15 demand, with about 20 demands per day. So really high dosing over a pretty long period of time in this patient as an inpatient stay. Patient alert and oriented, though, not having any issues, but still complaining of sharp and stabbing pain multiple times per day. RN and pharmacist in this particular case requested that we change pain regimen because they were just switching the PCA vials so quickly because they didn't have access to a really concentrated hydromorphone to use for this patient at their particular facility. So a decision was made to add on some IV methadone while working to decrease that PCA basal and demand in this particular case. So again, step 1, assess the patient, cachectic, albumin was 2.0, so that may be a sign they may have some more free drug available, perhaps. No interacting drugs, and we do have outpatient follow-up for this patient, so we're in good shape. Total daily dose, 256 of hydromorphone, again, using the 2 of IV hydromorphone to 25 of oral morphine, that's in McPherson's book. We get 3,200 milligrams of oral morphine, so at night, really a hefty dose. So then we're looking at methadone. So here's our conversion, say our Aurora one says, to consult palliative and hospice care in these sorts of patients, that's anything over 1,000. If you use the 20-to-1, which was their last conversion that they had there, it'd be 160 milligrams of daily methadone. The FDA says, well, it's less than 5%. So, that would be, again, dividing by 20. So somewhere less than 120, 160 is what the FDA would say. McPherson would use the 20-to-1, but then they cap it at a max of 40. And this is what I'm going to recommend as well. This is what I use in my practice. Cap it at 30 or 40 milligrams tops, even in these really high use patients. Rationale behind that is it really helps methadone really helps to upregulate opioid receptors and make opiates that are currently on board far more sensitive than they have been. They work a ton better once you start methadone in most cases. So you just don't need those levels of doses that these conversions are saying, 320, 100, 160. There was a small case series that looked at patients with really high doses. It was only 10 patients, but the maximum dose any of them ended up on was 40 milligrams a day as their steady dose. Again, very small number of patients, but in my practice as well, I have never seen patients need 160 or even 100 milligrams of methadone for pain control in these patients. So I recommend the McPherson method, maximum of 40 milligrams in these patients. All right. Step 4 is to individualize. So we decided, okay, we're going to start half our methadone. So we're going to cut our opiates by half as well. So they cut the basal to 5, cut the demand to 1, and started 20 of methadone. So 20 of oral methadone is 10 of IV. So 5 of IV was started every 12 hours. So we used the 1-to-2 conversion from IV to oral here. Again, there's literature saying that, we could have maybe done 5 3 times a day here as well, perhaps, to be equivalent to 20 oral, but it's still iffy. That's newer. Then monitor. So we monitored this patient. So days 1 through 5, still using pretty regular demands. But then by day 5, patient was reporting that the pain was slightly better. It was getting a little bit better. And so we increased the methadone on day 5 to 5 milligrams every 8 hours. And then we cut back on the basal and demand even further at that point. By day 12, so again, we're looking another week out there. Pain had improved quite substantially at that point. We have the basal now down to 0.5 milligram an hour, demand at 0.2, only asking for 7 demands a day. And they're starting to take an oral diet now. So we switch over to oral 3 times a day to help get rid of that last bit of hydromorphone that they're on, and switched them to as needed oxycodone 10. And that's what they were discharged on. And they were in pretty darn good pain control at that point. So you can see even this really high dose patient came down to 10 milligrams 3 times a day of oral methadone and as needed oxycodone.
Peter,
all right,
I'm struck by the time it takes to really see the effect of these drugs, and how there's a limit to using some of these in the hospice world to some degree. I mean, if you have somebody that is actively dying and probably has hours to days, it would be hard to work something like this into your routine for them. Maybe you could add it as an adjunct, a small dose, but this is really reserved for somebody that probably has weeks or months to live or more.
Yes, absolutely. For longer term pain control, absolutely. I completely agree. Now, here's a case where we may switch it over even in an inpatient hospice setting. And how we might do that differently. This case actually comes from my organization as well. So we have a 76-year-old male, metastatic non-small cell lung cancer, and they got meds everywhere. Transitioning inpatient hospice to assist with acute pain control, has pelvic and spinal lesions that are leading to acute pain, and he needs so bad he needs a PCA. And decision is to transfer to methadone. There is a PCA in the background here, I should note. I didn't talk about that here. I didn't on purpose, but they do have PCA demands available at first on this patient. So I apologize for not integrating that into the case here. I realize I did not. But then the decision was to, instead of doing a basal, they give a methadone. So current pain meds, Xtamza is an extended release oxycodone, so 75 every 12, and hydromorphone 4 every 3, with about 3 per day. So again, patient reports 4 out of 10 at baseline, but 8 to 9 when moving. So it's really movement and stuff where it's really causing a lot of issues. And there's no contraindications found to doing methadone. So we look at our daily dose, we get 180 and 60 for 240 of morphine. So converting to methadone, going through our same calculations here. We have 30 of daily methadone here for the Aurora conversion table. FDA says 10 to 20%. McPherson says, okay, they're over 65. You should use 20 to 1 on anybody over 65. So they're saying 12. So we have some variability, definitely, in the conversions on this particular patient. And here we individualized to the patient. This was at my organization. So we used the Aurora conversion in this case, and we went directly the whole dose over to methadone. So we did 10 every 8 hours of oral methadone in this particular case. Again, they are inpatient hospice, constant monitoring. You have to take that into account. This isn't an outpatient. This is somebody who's going to be monitored all the time. And then they decided to give PCA at first, but eventually ended up with morphine 30 IR every 1 hour. So the PCA was really the demand and the breakthrough at first. And the decision was based off of that setting and the acute pain that the patient was experiencing. So then on the monitoring end of things, the patient expired on day 3. So as Martin said, was it really worth it? But I will note that their pain was well controlled and they died what is considered peacefully, if you want to put it that way. They were well controlled with the methadone underlying and the PCA. So, was this worth it, as Marty stated? Was this somebody who would, you should even go through that? Should we have just done the PCA anyway? But I think my point here is that, yes, it can work converting the whole dose over using the conversion tables as well in the right setting. And it works. Good pain control is achieved. All right. That is all I had today. So quick summaries. There's lots of conversion methods, but my personal thing is not to start more than 40, especially if they're outpatient and not in a daily monitoring inpatient setting. Patients on large doses, consider starting just 20 and cutting their current opiates in half. That's a general method I've seen used multiple times. I think it's worked well. You don't have to cut their current opiates in half either. As Marty stated, just start a low dose and then titrate that low dose up while slowly decreasing their other opiates as well. I've also seen that method used as well in the adjunctive setting. Can consider more aggressive starting dose in patients with regular healthcare monitoring, such as that case 3. And constantly you're assessing risk benefit for these patients. If they are having acute pain and it's just getting really bad in those first couple of days, I have seen titrations within just a couple of days, moving from 5 twice a day to 5 3 times a day, to then a couple days later moving up. The risk is definitely there titrating that quickly, but the benefit of getting that pain control on board might outweigh that risk. Again, most everything from today came from McPherson. However, I do have a couple of that BGR method and that recommendation to change from 1 to 1.3 perhaps on the IV to oral is the reference at the bottom.
We don't have any questions, but I wanted to share just one quick case with you, Peter. You mentioned that it's pretty uncommon for people to use methadone both as a long-acting and a short-acting. And it makes a lot of sense because if you add more and more short-acting, you're going to impact the steady state, and it's going to be pretty difficult to predict where you end up. Though I've had a case or two where I've used that, and it's been in the cases of true morphine allergies. So I remember a particular patient that I was in the room 20 minutes after they got their first dose because I was curious to see how they were responding because we were hoping that they would get to go home. And their throat swole up, and it was really an emergency situation. And so we didn't want to use anything else in the morphine class. Sure. And so we ended up sending them home on a methadone for the long acting, as well as 2.5 Q3 hours PRN for breakthrough. Even though it may not be ideal, it certainly is an option in certain situations.
Oh, yes.
All right. Well, thank you, Peter. We really appreciate you sharing your wisdom, your knowledge with us today, and we will let everybody enjoy the rest of their Friday.
Thank you.
Absolutely. Take care, everybody.